Kia ora koutou, no mai haere mai for tonight's webinar on the scope and impact of nurse practitioners in primary care. My name is Katie McCulloch. I am a nurse practitioner, and tonight's topic will bring you a practical discussion that covers the essential steps of support and benefits of the role and how to support your nursing colleagues. Our speakers tonight are Karen Hoare. Karen is a Professor of Child and Youth Health and also a nurse practitioner. She works in partnership with 4 general practitioners at Goodfellow Family Clinic in South Auckland. She's implemented a number of models of care into general practice that result in case managing infants, children, and young people. Additionally, as a professor at Massey University, she is the director of postgraduate nursing program and nurse practitioner training program. Chelsea Wilmott. Chelsea works clinically as a rural nurse practitioner in general practice clinics across the lifespan in an urgent care, emergency, and prime. She is an academic and a clinical advisor at Victoria University and works within the National MP Training Program. She's an experienced senior lecturer and nursing medical educator and has a passion for challenging the status quo and driving the MP profession forward. Her special interest is interprofessional and intraprofessional conflict and the cultural relationship between doctors and nurses, horizontal violence in healthcare, and workforce development. She holds a variety of roles in healthcare management, is on professional advisory and policy working groups, and writes for several publications on topical health workforce issues. She's an executive member at MPNZ and is currently leading the development of an MP mentorship and professional development platform. We've got Dr. Kathryn Smith. She's a clinical director at Queenstown Medical Centre. Her experience is focused on general practice, accident and medical, women's and reproductive health, sexual assault care, relationship work and sexual problems, mental health and self-worth, gender diversity care, and LGBTQI and family health arena. We've also got Dr. Lucy O'Hagan. Lucy is a GP who's worked rurally and in urban settings for Māori health providers. She's also a medical educator for GP trainees and mentor trainees who just need some extra support or help with learning. She also writes a column for NZ Doctor called Just Wondering. Over to you, Karen. Thank you.
Thank you very much for the introduction, and it's great to be here, everybody, this evening. So who am I? I have been a nurse practitioner in New Zealand for nearly 15 years. As Katie said, I am a partner with 4 GPs, have been a partner for 14 years at Greenstone Family Clinic. Was probably one of the first nurse practitioners stroke nurses who bought into a practice with general practitioners back in 2009, 2010. So I came from the UK as a community practitioner with expertise in maternal, child and youth health. I'd been prescribing since 1998, and I emigrated to New Zealand in 2003, so 20 years ago. And practice nursing in 2003 wasn't a particularly attractive career pathway for nurses. There were no nurse prescribers or nurse practitioners in primary healthcare. So over a decade ago, I published a comparison of the drivers for practice nurse development in the UK, New Zealand and Australia. And my PhD looked at the value of nurses in practice, and I studied how they would use evidence-based practice. And the findings illuminated the value of new graduate nurses in general practice. So, with the burgeoning nurse practitioner role in primary care, young nurses coming out into general practice can now see the exciting opportunities. And we need new graduates in practice nursing and primary healthcare because of the older workforce of the baby boomers who are now retiring. So at Greenstone Family Clinic, we established a system to encourage third-year students who would come and experience practice nursing and see what a nurse practitioner could do. Back in 2009, the Ministry of Health expanded the new entrant to practice programme to include primary healthcare so that nurses graduating didn't have to spend their first year in hospitals. They could come out to primary care. So we've seen 23 third-year students through their final 10-week placement at Greenstone. We've had 14 new graduate nurses, and 4 of whom are registered now as nurse practitioners 2 Pacifica nurse practitioners, and 1 Māori. And a 5th one is currently in the programme. So what is a nurse practitioner? It's somebody who's acquired through additional education the expert knowledge base, complex decision making, and clinical competencies for expanded nursing practice. An expert nurse with a master's degree who provides clinical leadership. The master's degree denotes that they should have acquired the skill of critical thinking. They are not a doctor substitute. And as described by my good GP friend and colleague at Greenstone, we are a beautiful hybrid between nursing and medicine. So nurse practitioners follow a scope of practice, an area of practice. So those in primary healthcare who wish to practice, their scope is primary healthcare. Once registered, they're expected to maintain competency. And if they want to expand their area of practice, they have to demonstrate that they've got the requisite education, skills, and professional development to be able to do that. Every year, they attest to the fact that they have done some continuing professional development, and every 3 years, they have to do a comprehensive submission to Nursing Council to demonstrate that they have maintained their competencies, particularly in prescribing. So the 6 competencies are organised into 5 themes. I won't go through all of them, but the themes are clinical leadership, working in collaboration with health consumers, working in collaboration with other members of the healthcare team, equity. And equity is a really important principle in terms of why nurse practitioners were introduced into the healthcare system. And it's been my mission since becoming a nurse practitioner to try and managing the final year of the nurse practitioner training program at Massey to increase the numbers of Māori and Pacifica nurse practitioners to provide cultural concordance for our population. So on the 31st of March this year, there were 703 registered nurse practitioners. Less than 50 of them were Māori and less than 12 were Pacifica. And that does not equate to the demography of New Zealand. We have a 14% of our population is Māori and 6% is Pacifica. So also nurse practitioners, Māori and Pacifica nurse practitioners are really needed in areas where there are high populations of Māori and Pacifica people. Māori, namely in Gisborne and Northland, because practices are unable to keep GPs in this area. One Northland practice in Whangarei is entirely run by nurse practitioners. And they do crave the support of a GP. So nurses wishing to become nurse practitioners have to evidence their leadership, teaching and professional activities over the previous 5 years before they go into the final year nurse practitioners program. They have to have worked in a general practice or primary healthcare setting for at least 3 years prior to starting their final year nurse practitioner training. They should have a relationship with a clinical supervisor, either a GP with fellowship or a nurse practitioner. Some of the nurse practitioners that I have mentored, and I've mentored probably between 50 and 100 over the 15 years, have demonstrated outstanding leadership. One's the first nurse practitioner nurse who is a clinical director for Starship Community Health. She audited the number of referrals to paediatricians and allocated cases for nurse practitioners or nurses to home visit children with conditions that did not require input from a paediatrician. She reduced the referral to paediatricians by approximately 50% through this initiative. and other nurse practitioners develop primary healthcare services for children and young people in the youth justice system to ensure that these children receive the best possible healthcare that they had not received during their early childhood. Other nurse practitioners have written for New Zealand Doctor. Nurse practitioners provide standing orders for nurses and are role models for nurses. My colleague runs the bus that goes out into South Auckland to provide healthcare for people who aren't enrolled in primary with a primary healthcare practice. So the history and evidence suggests that nurse practitioners are not new internationally. They've been around in the United States since the 1960s and in the UK since 1982. Evidence has demonstrated good outcomes of care for nurse practitioners. There's many published articles around the outcomes. So what's the future? The Therapeutics Bill will be enacted in September 2006, and this bill will eliminate the final two barriers to nurse practitioner practice, which are Section 29 and Section 88. A recent consultation on the principles for quality and safe prescribing practice closed in October, and this emulates the UK's national competency framework for all prescribers. Nurse practitioners are in the Te Whatu Ora's health workforce plan. We need another 4,800 nurses at least in this country. So Professor Arrell and I have talked about a new College of Primary Healthcare Practitioners that includes doctors and nurse practitioners in primary healthcare. And we believe it is time for a change, and we are it. A little bit more about the nurse practitioner training program. So prior to the nurse practitioner training program, which started off as a pilot in 2016, and this pilot ran for 5 years between the University of Auckland and Massey. And in that 5 years, approximately 100 nurse practitioners registered. In 2018, after the pilot finished, during the pilot, there were only 288 nurse practitioners. So the national program that started across 3 universities in 2021 and has been expanded to 6 universities this year has seen a massive increase. And we're now looking at over 100 nurse practitioners registering every year. So what's the difference between a nurse practitioner and, say, a registered nurse prescriber? So a nurse practitioner has to have 4 years post-graduation in the area of practice that they want to register in. And as I said before, they have to have a master's degree. They're independent for prescribing authority. They can issue standing orders. They're not limited in any way in terms of their practice. They are responsible for their own practice. Registered nurses in primary care and specialty teams, they have a postgraduate diploma and they have to have been practicing for 3 years. They are independent prescribers, but they are overseen by an authorised prescriber, and they are limited to diagnosing simple common ailments only and long-term conditions that have already been diagnosed. Registered nurses prescribing in community health, they have to have been working for 2 years, and they use a work-based toolkit. They are independent prescribers, but they can only prescribe for simple conditions, useful for nurses working in schools and public health nurses. So over to you, Chelsea.
Hello, everybody out there. Lovely to have you all being part of this discussion that we're having this evening. There's a couple of questions that I've been asked to answer. So I'll do my best to run through things. And if anybody does have any further questions, you can always reach out and get in contact, and happy to help. So the first question that's a hot topic is, can you provide a brief overview of the nurse practitioner pathway, qualifications and educational requirements to be a nurse practitioner? So that's quite a big question. So I guess the first thing to say is that you have to begin the journey as a registered nurse, which means that you need to complete a Bachelor of Nursing degree. And, you know, the important thing to note here is that when we consider, you know, the registered nurse and then moving through into nurse practitioner, the knowledge that the foundational knowledge that's gained in that undergraduate nursing degree is very much staircase upon as a registered nurse moves through, gains experience, and then moves into that nurse practitioner space. So the Bachelor of Nursing degree in New Zealand is a comprehensive approach between secondary, primary, and mental health and addictions, provides really, really good, well-rounded, comprehensive skills and a really good introduction to clinical reasoning, evidence-based practice, and those are some of the foundational skills that are needed as you move through toward nurse practitioner. So you have gone out there and you have gained your Bachelor of Nursing degree and you started working as a registered nurse. And, you know, the thing that then comes is that time in clinical practice of gaining experience, building on your skills, moving from, you know, initially being very task focused. And as you gain more experience and confidence, you then start to think differently, look at things differently, and see things differently. And that's a really important process, that sort of building on that clinical experience and gaining more knowledge. And as I said, that staircasing really begins there. You may move through the PDRP pathway, which we use in nursing, Patricia Benner's model of skill acquisition from novice to expert. And that's quite important when you consider your preparation to become a nurse practitioner, because after multiple years in clinical practice, you're moving into that you're coming from novice into competent, moving into proficient, and then nurse practitioner, you know, we're interested in that really important time in that expert level, where you may be in a clinical nurse specialist role within the clinical setting that you work within across primary care or secondary care services. And along that sort of proficient to expert level journey, that's where we really want to see some postgraduate studies starting to move in to help you really build and open up your ability to be able to critically think, clinically reason, and you know, and really start to build on your academic foundation. So getting into postgraduate study, perhaps, you know, at that stage, it's a postgraduate diploma. You're looking at the clinical area you're in and you're helping to build your knowledge in that particular area. And then it's identifying, if you want to move on to nurse practitioner, an appropriate approved clinical master's degree program. And you really have to make a decision about which tertiary provider that you want to go to. There are many options across the country, and it really does depend on the right fit for you. Some academic providers have you know, different approaches and you need to do a bit of due diligence there and see which is a good fit for you. And then as you're sort of moving on, you're working through all of the master's degree program and thinking about moving into that, applying to move into that nurse practitioner space. You know, you may or may not have done RN prescribing before looking at nurse practitioner, you know, pathways, the end pathway, and there really is no right or wrong answer there. Should I do nurse prescribing before? Should I not? You know, we know that obviously if you do RN prescribing, there's you can do community prescribing, you can do a formal prescribing paper through a tertiary provider. And people do choose that as part of their master's degree toward NP. And we know that while it can provide some good consistency in developing your underpinning knowledge for common conditions, common medications, when you do move into that nurse practitioner intern year, it can be helpful, but equally we do have plenty of people that do come through who haven't had any prescribing, and they also, are able to move through things. So it isn't a complete prerequisite yet at this stage. And it really depends on your workplace. There's pros and cons. And so I think the thing, that's really important to say, and I know Karen touched on this, is that you are a registered nurse working in that expert level for 3 to 4 years prior to applying to move into that nurse practitioner national training program. There are other opportunities outside of the nurse practitioner training program to become a nurse practitioner, but the nurse practitioner training program does offer funding. So it is, it is definitely one of the more supported ways to become a nurse practitioner. And the other thing to think about is what else is going on for you in your workplace that can help prepare you for that transition from registered nurse to nurse practitioner. We know that the candidates that we have applying to our program, we know that that the 12 months prior is very important. We would hope that the registered nurse at that expert level, clinical nurse specialist level, was running nurse-led clinics, that they were attending meetings, they were building those leadership skills, they were joining different groups, they were attending conferences, doing audits, contributing, that they already had connections with a mentor. They were really setting goals around how they can evolve into that role as a nurse practitioner. And from a clinical skills point of view, one thing that we really want to see, and we're very excited to see, is when clinical nurse specialists who've completed the advanced assessment papers are actually implementing those skills in their everyday practice as registered nurses. So they are starting to do the physical examinations. They're starting to get involved in good clinical discussions with colleagues, and they're taking more of a leadership approach with what they're doing. All those things help with that massive transition from registered nurse over into nurse practitioner. And so the nurse practitioner program, as I said, is that there's an annual application process. You have to meet the B grade average and have met all of the prior requisites to get in, including master's degree, and have lots of things set in place within your clinical setting. You need a clinical mentor. You need a really supportive workplace who isn't just focused on that 12 months of nurse practitioner internship. It's actually beyond that as well. How else are you going to become supported once you are newly qualified? Because even though we know that the nurse practitioner intern year is very challenging, it is also challenging once you are newly qualified, like how it was when when registered nurses or doctors were newly qualified. There's really big things that happen, so you need to be well supported. And essentially in that nurse practitioner intern year, you go through a process, registered nurses go through a process of coming in as expert nurses, and they have a deconstruction process that needs to happen to be able to move away from that registered nursing headspace and way of thinking about things and reconstruct with a new mindset and a new model and a new way of thinking as a nurse practitioner. And it's very challenging to try and as with anything, it can be hard to really understand the nuts and bolts of what nurse practitioners do and how they go about delivering the care that they do. And that nurse practitioner intern essentially starts to embody that role as they learn more about it and practice doing working through the model of care that we use. And it's kind of like that perception of the registered nurse the general public has, that kind of caring, caring persona, but we know that when we went through our registered nursing education, that we soon realized how big that registered nursing role was beyond the caring. That's a similar process. You know, nurse practitioners are seen as this autonomous lead care provider, and that they can work at a similar level to that of medical doctors. But you know, until you're sort of in there figuring it out, it's hard to really internalize and understand that journey. So if you are wanting to become a nurse practitioner, go and spend some time with a nurse practitioner, sit in on their clinics, you know, get involved, come and talk to, you know, any nurse practitioner is usually pretty open and pretty happy to have registered nurses coming in and learning about what they do. It's a really big part of working out if that is what you want to do and if that fits well for you. And so I hope that was helpful in some way. The next question I have been asked to talk about is the nurse practitioner model of care. And so you may have heard the term out there, blended model of care, that nurse practitioners are function, and Karen mentioned that as well, in between that space between nursing and medicine, and that is a mixture of medical sciences and nursing sciences. So it can be quite hard to sort of figure out what that actually means in a practical sense. And, you know, it's a really interesting concept because it does actually provide quite a unique perspective and quite a different approach to how, you know, the questions that nurse practitioners ask and how they move through a consultation or an interaction with a patient. And so it does take on average around 9 years to become a nurse practitioner with, you know, 2 degrees. That's just to reach that sort of beginner status. And the nurse practitioner training program, what we do within that is we really do teach a sort of a base core foundational model of care that can be applied to any clinical setting. But the nuts and bolts of it are that the framework that the interns work through is essentially that core foundation. And as I said, they may be in different clinical contexts, different settings, but the core of what they do, how they problem solve and work through their process is the same. And it's obviously then adapted to the setting that they're in. So when we talk about model of care, what we're referring to is that real core foundation and what constitutes that process that nurse practitioners work within to be able to action and deliver that healthcare. And the model in New Zealand is specific to New Zealand. UK has a different model, and we see that nurse practitioners who come to New Zealand from the UK do have to go through a retraining process because it is a different role, and New Zealand is at a different, you know, has a different level of autonomy. And the US, the model in America is different again. It can vary from state to state. So we've got a really unique model here. And it may surprise you that autonomy that's inherent in the nurse practitioner model, it has been a really gradual process. As I've said, staircase through that undergraduate degree right through. We're not suddenly just throwing these highly experienced nurses out there without the correct preparation. And so the nurse practitioner model is that roadmap or that sort of actuality of how that nurse practitioner conducts a comprehensive assessment. So the framework that they utilize includes that assessment, really comprehensive, wide assessment, so that you can then move into interpreting that information and creating differential diagnoses. You may need to, as part of that workup, order bloods, look at imaging, you know, do some tests, then interpret those, and then create your working diagnosis. And then you go through the process of working through your treatment plan, your review plan, and your wider management plan. That can be pharmacological and non-pharmacological, and of course there's follow-up. So those of you that have gone to medical school that are in the audience, it's a really similar comprehensive framework that we use in our nurse practitioner model of care. And it's very detailed, very rigorous, and it's very research and evidence informed. And as that name implies, really comprehensive. And the thing that is really important to say is that while nurse practitioners do come from that registered nurse, prior experience, the nurse practitioner model of care does have a medical foundation within it. And it really needs to, so that nurse practitioners can work through that level of complexity that they do work through and deliver an appropriate and safe standard of care. But that's just that one aspect of what the nurse practitioner utilizes when they take pieces from the biomedical model. And so, the blended component is that nurse practitioners, as I've said, really begin with that heavy influence in that sort of nursing philosophy model, and that's deeply embedded in their worldview. So that means, in a practical sense, that it's actually the way that nurse practitioner will ask a question, the cues that are interpreted, and that sort of focus of not being able to ignore what is in the room that's not being said, and sort of having a really purposeful intent without any hesitation to lean into that. It's the sort of how the nurse practitioner thinks and problem solves that would be different to somebody who has just gone through traditional medical school. And so we all know that, clinical guidelines for, say, managing atrial fibrillation or heart failure, but it's that artistry within ourselves as clinicians that really helps to support and shape the plan and that healthcare journey for patients. And nurse practitioners have begun to learn about patients in a really different way. We've started with washing naked bodies and going through that whole confronting process. It's quite different to how the relationship that medicine initially creates with the body, which is, more in that sort of anatomy perspective with cadavers. So all those things really do inform how we blend our model and how we deliver the care that we do. And it can be very challenging for registered nurses moving over into that medicalization process. But, what happens is that at the end, and as they move on and become more and more experienced, they just become this lovely blended practitioner. And so we do have a different perspective, and that's why nurse practitioners don't like to be referred to as replacement doctors, because we have our own sort of approach and way of working with patients. So the next question to talk to quickly is how to implement a nurse practitioner intern within a general practice setting. So it really needs to begin with identifying a registered nurse who you feel that would want to go on and become a nurse practitioner. Some medical centres and urgent care centres across the country do purely advertise for nurse practitioner interns. They're willing to just support them in that final year. Others will, succession plan and move nurses through into those advanced pathways. What we'd love to see from our perspective in PTP is that these candidates are moved on to nurse practitioner intern contracts. So meaning that they are removed out of that traditional registered nursing role. They're working as an intern. They're starting to see patients alongside their mentor, who's a nurse practitioner or a GP, and that there is a model set up within the practice that allows time for the intern to be interning and taking a long time to do an assessment, do that learning, work through that process, and then having time with their mentor to talk through things. And that real sort of apprenticeship model as their mindset changes and they have to work out how to move through those models. So time to learn, time to ponder, and time to discuss. And as I said, it's not a 12-month approach. It's certainly an ongoing commitment, and workplaces really need to consider how they will support new nurse practitioners beyond their study. And we are looking at ways of building a similar model to the GP registrar training program with NP 1, 2 and 3, so that we've got some consistency, and we've also got a really good strong foundation there with a transparency in the type of support that's needed. And so Auckland University this year have piloted a program for new nurse practitioners called the Nurse Practitioner Transition Program. And that concept is sort of the beginning of that way of providing a nice level of support. That program is continuing on. It provides the medical centres with and other primary healthcare based employers of new nurse practitioners with a level of funding to help support with the things that are needed, such as longer appointment times, access to clinical mentorship, professional development. It provides financial support to help those healthcare providers be able to adequately support their NPs. And nurse practitioners, I've just been asked quickly to talk about nurse practitioners as locums. So nurse practitioners can be used as locums, and they are used across the country as locums. Nurse practitioners can join up with a locuming agency, or they set up their own locum contracts with independent medical centres, and they work across a variety of contexts. They're within a medical team. In primary care, it's a very similar role to that as a general practitioner. In secondary care, it's a registrar, role, similar role. And there are differences in how nurse practitioners are used across the country. We're not seeing consistent full role utilisation yet, which is something that we would love to see grow and change. You've got variances in places such as emergency departments, how nurse practitioners are working. And the important thing to say, same in general practices, the important thing to say is that a medical team, should not be dictating what a nurse practitioner can or cannot do. Nurse practitioners have their own role within patient care at that autonomous lead care provider, and they have the skills and capability to see complexity. And that's an important point to note. So we do want to see nurse practitioners being utilised well. And there's many career opportunities for nurse practitioners in a variety of settings, and we're only going to see more and more of that come in the future as we look at developing specialist role pathways. We have gypsies, we'd like to see NIPSIs, as well as, there's also board of director roles, clinical leads, clinical directors, academics, policy. There's so many opportunities for nurse practitioners, and it really, we know that the need is high in all aspects of the healthcare system. And, it shouldn't be about medicine versus nursing. It's about people and teamwork and sharing ideas and creating access, working together, and, helping to navigate that wild storm out there that, not just one professional group can navigate. So thank you very much. Happy to take any questions and hope that's been helpful in some way.
Wonderful. Hi, Kathryn. I'm so glad we could get you to join on.
Hi. So I've been asked to talk basically from the general practice perspective. So I'll give you a bit of a rundown on the Queenstown Medical Centre. We've got a $20,000. We've got 20,000 patients, and we're quite a large practice. We've got 25 GPs. We currently have 4 nurse practitioners. We have 4 different practices, and we have an urgent care. So we have NPs working both in general practice and in our urgent care. And I was to speak to how you can kind of have the training, be supportive of new MPs coming in. So 2 of our MPs, 2 of them have been trained in the UK, 1 of them has been trained in the US, and 1 within New Zealand. So we've got quite a mix there, and there's different training needs that are required. But I was to speak to the role of the GP in nurse practitioner internship and mentoring. And I kind of thought there's sort of 3 words that struck me for this is I've got safe, supported, and structured. And I think that structured part of it is really, really important. So in terms of the role of the GP, I've been involved in supporting and mentoring 2 NPs so far, plus working with another 2 that are new. So over the years, they've been a very important part of our practice. And it's got to be a very supportive and nurturing growth model. You need to build a culture of ongoing learning and create a really safe environment for NPs to grow and develop their skills. One of the things that struck me from what Karen said was that, you know, we do have a bunch of GPs that are my age and aren't going to be practicing in the next 20 years or so. And we haven't got any or enough, definitely not enough young doctors coming through that want to get into general practice. And there's all sorts of politics and health reasons behind that. But there's a vast opportunity for NPs to come into general practice and, as Chelsea said, really expand their scope of practice. And I think as GPs, it's really important that we are open to that. And we see that as wonderful and exciting rather than, I don't know, a potential threat or sort of stepping on our patch. I think they do, they complement beautifully and they are part of our general practice team. And after listening to Chelsea and just how hard it is and all the training and all the time that's put into it before you even get to prescribe or see patients on your own, it's just phenomenal the commitment that NPs make to get into this role. And I think as GPs we have to absolutely support and respect that. So our practice is set up for sort of an NP internship. And so the way it works is our newer NPs will see 2 patients for about 30 minutes each, and then after that hour have a 15-minute catch-up with whichever GP they're working with. And then the GP would see 4 patients and then have that 15-minute catch-up with the NP unless there's something really urgent, and then of course the GP would come through. And then there are bi-weekly teaching sessions where you dedicate an hour to discussing patients and learning and developing case plans and looking at lab results and x-rays and that sort of thing. So it's not NPs seeing patients on behalf of the GP, especially in that mentoring and training internship role. It's about learning and it's about supporting a learning environment. The next question was how clinicians can set up the practice to support NPs. And this is ironic because I'm so hopeless at IT, but one of the most important things is making sure that IT-wise everything's set up correctly, that they understand how your patient management system works. And down here in the south, the Southern Nurse Practitioner Network, they've created a fabulous list of all the things that need to be done before the nurse practitioner begins, so that the transition is smooth and not threatening and not stressful. And also a really good orientation to the practice, making sure that they know who everybody is, what their roles are, who's comfortable with the door being knocked on if the doctor that you're working with is not available, how the system flows, so that there is a sense of safety and support for new NPs. And one of the questions that I noticed that came through earlier on was this concern about certain areas of practice that nurse practitioners may be inexperienced in or not be confident with. One of the interesting things was one of our English nurse practitioners who's moved on. We have new ones now, but at that point she had done a lot of sexual health, and so we put her in our sexual health clinic. But our sexual health clinic was also a family planning clinic, and she'd never put in a speculum and didn't realise that she was going to have to do that. So that was actually, we all missed that, and it was a real sort of sentient learning exercise. So we went through a training session on speculum insertion. So there are going to be areas where there is lack of experience. So it's really important that the nurse practitioner feels confident in addressing that area of concern, and that the practice that they're working with creates opportunities to expand that scope of learning and that scope of practice. And it can be really rewarding to create these opportunities and watch the NPs grow in these areas. So they need to be exposed to a wide variety of patients and extend the breadth of scope of practice for them that they're comfortable with. So I think that's been really good with both our urgent care and our general practice, that we're able to provide that. We've got 2 NPs currently who only work in our urgent care, and we've got one that's working in both urgent care and general practice. And one of our really experienced nurse practitioners is pretty much working totally in the role of a GP, 100%. She does everything. There are certain limitations with prescriptions, but that's all coming into, I think we're being more realistic about allowing NPs to function totally in the role of GP. And then you've got, I work as a med-sec doctor, and I know that in an area in the North Island, there's actually an NP that's running the whole med-sec service and is the clinical lead for that service with GPs that she organises, and she's amazing. She's an absolute force of nature, and she's doing really good work. So there are so many different opportunities. The other thing is ensuring that there is lots and lots of clinical experience, and keeping those clinical hours available right up to the end of that nurse practitioner internship, so that there isn't a loss of momentum, that there's real confidence. And we've got to remove the barriers around the strongly held belief that as GPs we do have to do it all. We don't, and we can't, and there's not enough of us. And NPs are coming in and making a huge difference in communities. We've got a video that we have playing in our practices that it's a rolling over video that actually explains the role of the nurse practitioners, so that when our patients come in, they understand it. And we've got two of our NPs have their own patient population now, their own regular patients. So the other really important thing is that the other staff and the practice are supportive of the nurse practitioners. So that's right from our first impressions or our reception team, encouraging them to offer GP or NP appointments. We've had very little negative feedback from patients, and most of them really enjoy seeing nurse practitioners. And the message is that it's a no lesser valued service than seeing a GP, that actually you're getting in some ways a uniquely different service, especially with the nurse practitioners that have half an hour to spend with patients. And one of the things I've really enjoyed is the opportunity, for patients to sit with a nurse practitioner. They get 30 minutes with that nurse practitioner, who can be really curious and explore all sorts of other things that might be going on, systems reviews and that sort of thing, that as a GP we don't have time to do in 50 minutes, and then potentially more time with the GP coming in to help. So the vast majority of patients really love that service and feel heard and supported. Our NPs, as I say, some of them are often in urgent care on their own, sometimes over weekends, running the urgent care. They attend peer review and function just the same as GPs, and ongoing clinical support on a day-to-day basis. And sometimes we'd have nurse practitioners presenting in our peer review meetings. So I've talked about them covering weekend shifts. So the other thing that is really important is this whole team approach to healthcare. General practice is changing. It really is. We've got healthcare assistants, we've got health improvement practitioners, we've got HIPs and HICs, health improvement coaches, and now we have nurse practitioners, and we have social workers that come in and out of our practice now. It's the evolution of general practice, and nurse practitioners are part of that moving forward. So one of the things I probably want to do is just dispel some of the fears and myths that GPs might have about having nurse practitioners within their practice. And this was actually a comment that I spoke with one of the NPs that I work with quite closely, and she says, nurse practitioners are not here to take over the world. They are providing exceptional clinical care and have achieved their qualifications on a different pathway to us. There's plenty of work for all of us, and we need to work together to deliver patient outcomes. It's not right or wrong, it's just different. And I think that's a kind of really nice way for me to finish, and I'm happy to answer questions later.
Lucy, wonderful. Thank you for signing on.
Ina koude katoa, ko te tea te moa, ko mata o te awa, no hawera ho, ko noho o ki waikanai, ko Lucio Hagan, toko ingoa. Lovely to be here. I think I'm here as the cheerleader, actually. So I am a GP, and that is a very powerful part of my identity. But I'm also an enthusiast for ideas, and I think that if you've come to this webinar, you're sitting on the right side of history, because we totally need nurse practitioners. We've got a workforce crisis that isn't going to be solved fast. I've just read today that Canada by 2030 will be 200,000 doctors and nurses short. So we're going to be competing on an international stage with them. It's going to go badly. From my pepeha, I have worked as a rural GP, and I think one of the reasons why I don't feel particularly challenged by the idea of nurse practitioners is that for the whole of my rural career from 1995, we worked with rural nurse specialists, and the closest ones to us were 2 hours drive away in Haast. They were 200 kilometres from the GP who was giving them advice. And so for me, it's not really a thing that it's not possible for a nurse to do those sort of roles. And then, of course, we've had these most fantastic nurse specialists in breast care, gastro-renal. And so I think we had this sort of experience of the upskilling of nurses. One of the places where it historically has been very slow was for practice nurses. There was always this, in the 90s and the early 2000s, there was a bit of a ceiling where there wasn't much of a career pathway. So it's actually fantastic that we're getting nurse prescribers, and then people can move on to be nurse practitioners. So what I want to get us to do is to think about how this is going to look in 10 years. And the world is changing so fast, it's really hard to know. Let's not even get started on how AI might come into it. But really, I do think we need to start thinking about primary healthcare. Although a very intelligent person said to me the other day, they always thought primary healthcare meant the hospital because that was the top. So it's not actually a very good term, and I quite like community care. And the reason we want to think about this is that words matter. And if we just continually talk about general practice, then we're talking about a particular version of community care, which historically has been owned and led by doctors, and where there's been an employee-employer relationship. And that really is going to be problematic if we think about it like that going forwards. So I think probably community care in its various forms, some of that might look a bit like general practice. So I now work for Ngāti Toa in Porirua, and I think of myself as a rata hauora for an iwi health provider. And that actually completely changes the way that I think about my job. I also am involved in teaching young GPs, and what I would say is that if you were starting from the beginning now, and you had no history and you had no kind of things that had led us to this place, what you would absolutely do is that you would train GPs and nurse practitioners wanting to be in community care. You would train them together in their postgraduate training. You'd be absolutely dumb not to do that. That may not happen, but I think that if we were using our imagination and going, like, there's a lot of evidence that interdisciplinary training leads to increased teamwork, and I think it also would help our sense of sort of collegiality and trust and that sort of thing. We might still do our own professional exams, but I think ideally what would happen is that an NP intern could then go into a community-based training with people who are doctors, or whatever we're going to call them. So I think there are still some pockets of resistance in general practice or amongst doctors, and I think that's okay. I think we have feelings at times, and and change creates kind of anxiety in people. But I think it's good to understand what those feelings are. So I think that there's some sort of concerns that you can't teach a nurse to do differential diagnosis. I spend my life teaching GPs how to do clinical reasoning, because some of them aren't that good at it either. I have had the experience of teaching practice nurses to do clinical reasoning for the area of sexual health. And it was a really interesting process, because I think it is a really different way of thinking, but it can be taught, and they can totally learn how to do it, and in the end do it better than me for that area that they were trained in. I think the other thing that I found with nurses upskilling to that sort of level is the other thing they had difficulty with, which took a while to get their head around, was the buck stops with me, that I'm responsible for this decision. But again, I think with experience that comes. Sometimes people are worried that nurse practitioners will over-investigate or over-refer, and I don't think that the evidence really stacks up on that. Certainly GP registrars refer and investigate way more than I would. And I actually think that's part of learning. Part of learning is sending a referral and getting a reply back and seeing what happens with that. So I don't particularly have a difficulty with that. So I think we want to think about how we're going to move forward to achieve this vision and really make community healthcare a place that people want to be, because we've got health professionals there who are interacting and having a really good time and giving really good care.
We now have time for a panel discussion, so please bring forth your questions and we will direct them to the panel. One of the questions that is just talking about the MPTP program, and I think it is quite important to see how many people we are getting coming through, the numbers that are coming through. So how many have applied this year for our MPT program, and what's that looking like? How's that forecasting? I know Karen sort of touched on it earlier.
I think the last count that we heard from Rachel, who's head of the NPTP National, was that there was 137. We've certainly got 28 candidates that we are putting forward for next year at Massey. But what is exciting, and I'm sure it's okay for me to relay this, is that Te Whatu Ora are hopefully going to expand the more than 100 that they've committed to fund next year. So we're getting more funded places than the 100. We've got 6 universities now, so 2 more universities have joined us this year. That's Waikato and AUT.
Brilliant. It's very exciting for the program. And Chelsea, you mentioned that the structured intern program, so for when MP novices are out in practice, that when will that be coming into play?
At the moment, this year, the University of Auckland's running a nurse practitioner transition year as a pilot that's going to continue next year. We're at MPNZ, we're looking at developing an educational sort of structure and you know, building a process that's similar to that of the GP registrar training program for primary care with a fellowship, looking at fellowship pathways. I know Lucy and I have had many discussions about about that, and got some blue sky thinking there. And so we may also see in time that the nurse practitioner year, the intern year, is moved to a extended out to a 2-year internship training. And you know, so there's potentially lots of things shifting and moving in the future, you know, for primary care. And you know, there'll also equally be plans in place for better supporting secondary care integration of the role as well.
I mean, that's really exciting. For people who are working in small practices or have reduced access potentially to GPs, or for colleagues, and this is, I guess, for everyone in the panel, because Lucy and Kathryn, you've mentored novice MPs and MP interns. How would you support people to get the preceptors that they need if they're working rurally? What are your thoughts about supporting our rural MPs, or MPIs, I should say?
From a program perspective, we require the applicants to have a plan in place with the facility they work within to be able to provide access to a mentor. There are some nurse practitioner candidates who apply who cannot have their internship requirements fulfilled where they work, so they make arrangements to do their interning hours at a different facility in order to access a mentor. So that is, and sometimes in the rural settings, sometimes even in urban settings, interns do need to, have moved to different sites to be able to complete what they need to complete. So that, there's some flexibility there, but what's key is consistency with those, if it's going to be 1 day a week somewhere or 2 days a week, or that there's an actual bigger, well thought through plan.
And for NPs who have no longer novices, that are working in those community outreach teams without that readily accessible GP support, how can we make sure that they are in a safe and structured way, given that wraparound if they need it?
So if they're experienced nurse practitioners, they should be part of a peer support group, where they can take cases to their peer support mentors. And additionally, I think one of either Kathryn or Lucy spoke about that professional accountability. And when I went to nursing council and spent the entire day going through 6 cases, presenting for over an hour why I should be a nurse practitioner, I think one of the most pertinent slides that I put up was who I'd call if I needed help, so I'd have the personal name of the surgeon, the personal name of the pediatrician that I'd need to call. And I think that's something that we teach them in the program, that you do not work on your own. You always should be keeping yourself safe, making sure that you're asking somebody else who's more experienced, etc. So that whole professional accountability was certainly something that was driven into me in the UK when I started prescribing, and it's something that we definitely talk with our nurse practitioner trainees. So one of the sessions, we've got block course days next week, and one of the sessions that I'm doing is the Health and Disability Commissioner's complaints, and also MPS, the Medical Protection Society, some of the cases, so that we can go through some of those cases, so that the nurse practitioners understand what professional accountability means, and that the buck stops with them.
Brilliant. Thank you for that, Karen. Does anyone else want to add to that?
Nurse practitioners work in collaboration, that they are autonomous, like doctors are, but they work in collaboration like doctors do. If you're in a real life situation with a patient and you don't know what to do and everybody around you is really busy, you pick up the phone and you call a specialist. That's absolutely, as Karen said, drilled in as a fundamental important process of how you are accountable and safe in what you do. They're not out there, in a back corner making unsafe decisions. They're very collaborative. And I think because the registered nursing profession is so terribly regulated and very, very strict with what registered nurses can and can't do, they've got nurse practitioners have come from a world of regulation and having to justify everything. So they're very used to that collaborative model and knowing their limitations, and they're generally very willing to collaborate.
So speaking about Chelsea, how you've mentioned, as nurses, we have very strict parameters around what we can do. Can we just get a bit of clarification? In terms of nurse practitioners in primary healthcare, what can they not do in the primary healthcare setting?
Over the years, the legislation has changed considerably in New Zealand The Magic 8 big pieces of legislation have been amended over the years to remove many, many barriers for nurse practitioners that were to be able to do and provide services that were previously only being able to be provided by medical practitioners. And so in the general practice setting, the current one of the current restrictions on the role is Section 29 medications. That is going to be completely removed with the new therapeutics bill. So that will alleviate any restrictions around some of that prescribing. And other than that, you know, the sky's the limit with regard to how the workplace build the model of care for that role's implementation and how that role is upskilled and used and integrated into the team. There are lots of different ways that that role can be developed to provide more advanced services, and we will only see more of that in the future.
Just to you, Kathryn and Lucy, how do you, would you have any advice for general practitioners who haven't implemented a nurse practitioner intern, but would like to start on that pathway?
Most people who've done it think it's fantastic. They can't understand why they hesitated. You might meet one GP out of 100 who had a not great experience, and that's life. There's probably that many who have not great experience with a GP registrar too. So I think do it. I think it is a teaching role, and if you've had other teaching roles like with GP registrars or medical students, then you might feel better equipped to do it, because it's slightly challenging because you're actually coming from a medical model and you're trying to sort of bring someone towards that model. So it's a slightly different way of teaching, in some ways a little bit trickier. Having spent a lot of time with GP registrars, I would encourage anyone who's teaching clinically to sit in with people. I think it's interesting sitting in with any other practitioner, even if they're learning. I think it's very interesting for doctors to sit in with nurses, because oh my goodness, you immediately see how they're coming from a different place to us. I remember sitting in with the gastro nurse in Dunedin, and she basically spent probably the first 4 or 5 minutes just getting to know the person before she asked a single question about their medical thing. And it was quite astounding to me. So I think that there is a, and you know, GPs don't like to be told that nurse practitioners are really good at the holistic care thing, because we like to be good at that too. And I think within medicine, we probably are the best at it. And I think we are really good. But I still think that that nurses are coming in from a very different philosophical position.
I'd just say to any GPs out there that are considering having nurse practitioners in their practice, along, you know, same as we have 5th year medical students, we have GP registrars. A lot of us love teaching. We think it's really important. But you can put out an ad for a fully qualified nurse practitioner to come in and join your practice. Just do it. It just makes your life so much easier. There are more than enough patients to go around. It's not going to threaten your patch. Don't be afraid to have an NP come in and do a locum for you. You know, I suppose that's the big message is don't be afraid to do it. And if you want to teach, if you're teaching registrars or 5th years, teach NPs as well. It's really not that different a process. But be open to teaching and don't be afraid to advertise would be what I'd say.
Can I just chip in here as well and just say that, you know, some of the things that I've done is just change the way that general practice looks after patients. So one of my big successes was introducing the Best for Baby scheme. So we keep pregnant women. We look after them with the midwife through the pregnancy. And that just means that we've got incredibly good maternal pertussis immunisation rates. You know, our rates are the same as the UK and Australia. And it's that's what I see a nurse practitioner doing, is coming in and looking at how a practice operates and thinking about, well, how can we case manage these patients a little bit differently so they're not just turning up for acute presentations.
Lovely. So we are coming to the culmination of our webinar, but I guess one of the things I wanted to ask was and this is for everybody, so what advice would you have for individuals considering a career as a nurse practitioner? Just some quick fire points.
Well, I've had a fantastic career as a nurse practitioner. My expertise is in paediatrics and youth health. And I'm coming towards the end of my career, and I would say I have thoroughly enjoyed it and feel very privileged to have done it.
Kelsey, what are your take-home points?
Along my nurse practitioner journey, one of the most important things that's happened to me is just being able to have to find a mentor and just have those really vulnerable conversations and just be really accepted and and treated with kindness and respect, and it's in those moments when you really feel vulnerable and you're not sure, and you have an experienced GP or NP to just really move you through and help you find your feet. And I think that mentorship is such a gift and a special skill. And we've all met people like that in our lives, and I think that's one of the most important parts of your journey, is having good people around you.
Kathryn, do you have any take-home points?
I think that that any career in health where you get to support and nurture people through their health journey is an honour. And I've had the privilege of working with some fabulous nurse practitioners and some fabulous GPs and some fabulous trainees, student doctors and registrars, and it's just a different pathway to getting to be able to care and nurture and to serve, and there is nothing more rewarding than adding value and helping in the lives of others. It's an honour, and it's available to NPs if they want to go down that pathway. And I suppose there are lots of GPs out there that want to support and mentor, and there are lots of experienced NPs out there that want to do the same thing. So it's just like, dive in, do it.
Thank you so much. And Lucy?
Yeah, just do it. Totally do it.
Yes.
I mean, I'm really excited because I've spent a lot of my life sort of learning about and thinking about the philosophical basis of general practice in those terms. So what community-based care is about for a doctor. And so I'm so interested in what nursing is going to bring to that conversation, because bring it on. It's going to be fantastic.
That will be all for our webinar tonight. I really appreciate everyone for joining us. I really appreciate our panelists for giving up their time and speaking on tonight's topic. Again, thank you so much to everyone for coming tonight, and have a lovely night, everyone. Ka kite.